Hi, good evening, everybody, and welcome to Nivarana's forum discussion on the occasion of World Cancer Day. For those of you who are hearing about Nivarana for the first time, Nivarana is a public health information advocacy platform which was started in 2022. We aim to bridge the gap between public and public health by making complex information accessible and easy to understand. And we wish to empower people with the right information with the hope that more people would begin to be bothered about the public health practices in the country, understand what is lacking, and ultimately demand a change. Public Health Forum is one of our initiatives where we have solution oriented discussions of problems with experts in a panel and in the audience. Today, we are going to discuss a very neglected toxicity of cancer care. Today is World Cancer Day, and we are going to discuss a very neglected toxicity of cancer treatment, which is financial toxicity. And to discuss this, we have four experts with us today. Uh, and at Nivarana, we always believe that the expert is first the person who has gone through the disease or the problem and faced it very closely. And for that, we have Prabhat Ranjan with us today. Prabhat Ranjan is a social worker from Patna in Bihar. He was the caregiver for his father, Gopal Chandra Jha, who was diagnosed with stage 4 lung cancer. And he'll be talking to us and sharing his story of how, all the difficulties that he faced and his father faced while seeking care for lung cancer in India. We also have with us Charmaine Blanchard. Charmaine is a medical practitioner specializing in palliative care in Johannesburg, South Africa. She's an expert in the domain of home based palliative care and has a keen interest in exploring ways in which palliative care can be offered as an affordable multidisciplinary service to patients and their families. And with the help of Charmaine, we'll be understanding today how things are different in India and in South Africa, and if India can learn something from South Africa. Thanks for joining us, Charmaine. We also have Dr. Ravi Kannan with us. I'm sure all of you present here already know him. Dr. Kannan is a surgical oncologist. He is the director of Cachar Cancer Hospital Research Center in Silchar in Assam. And he has led a team at Silchar to demonstrate that it is possible to deliver high quality, low cost cancer treatment in one of the most resource limited parts of the country and also a very challenging terrain. And for his contribution to care of people with cancer in India, he has received Padma Shri and the Ramon Magsaysay Award. Thank you, Dr. Ravi, for joining us. We also have Vandana. We're just waiting for her to join. Vandana Mahajan is a cancer survivor and a palliative care counselor who is trained in palliative and bereavement counseling with a postgraduate diploma in integrative counseling. She draws strength from her lived experience of cancer and is one of the most active patient advocates in the country. And for her contribution to care of people with cancer in India, she was also facilitated by the president of the country. And she will soon join us. So yeah, today we are going to talk about cancer's financial toxicity. And प्रभात जी, मैं पहले आपसे शुरुआत करूंगा. आप हमें थोड़ा बताइए कि कैसे इस बीमारी ने आपके परिवार पे असर किया और क्या-क्या कठिनाइयाँ आपने झेली इस बीमारी के वजह से.
बहुत बहुत धन्यवाद। मुझे आप इस पैनल में निमंत्रित किया और मुझे बुला के अपनी बातों को रखने का मौका दिया। इसके लिए आपका तहे दिल से शुक्रिया। और यहाँ पैनल में जितने भी हमारे वरीय डॉक्टर्स और जो भी आप वैरियर्स कर सकते हैं, मैं सबका यहाँ अभिनंदन करता हूँ। सबसे पहले मैं अपने बारे में कुछ बता दूं। मैं प्रभात रंजन एक सामाजिक और धार्मिक कार्यकर्ता के रूप में बिहार सहरसा बिहार स्टेट के एक सहरसा एक छोटा सा जिला है, उससे बिलोंग करता हूँ। और फिलहाल अभी मैं पटना में रहता हूँ और फादर भी यहाँ पटना में थे। फादर हमारे रिटायर्ड इंजीनियर थे। पिछले साल 2024 में के फरवरी में उनका लंग कैंसर का डायग्नोस हुआ और 4th स्टेज लंग कैंसर था उनको। अ, और ये पिछले महीने में आपको 11 तारीख को 11 जनवरी को इनका देहांत हो गया। तो इस बीच में ये मतलब 11 महीने का जो भी मेरे आर्थिक और मानसिक तनाव से मैं गुजरा हूँ, मैं उस पे ही अपना फोकस करूँगा। और आपको इस बारे में मैं आप लोगों से अपनी समस्याओं को और और भी जितने भी लोग हैं जो इस ऐसे ही समस्या से जूझ रहे हैं, वो कोशिश करूंगा कि उनकी बातों को मैं आपके सामने रख पाऊं। तो जब पिछले 2023 के दिसंबर में मेरे फादर खांसी की समस्या से ग्रसित थे, तो अपने पटना में ही लोकल डॉक्टर से उनको दिखवाया। तो वो कुछ टेस्ट वगैरह किए और उनको लंग्स में कुछ समस्या लगा, तो उन्होंने मुझे सुझाव दिया कि आप बेहतर इलाज के लिए मुंबई टाटा मेमोरियल हॉस्पिटल जाएं तो वो ज़्यादा बेहतर होगा। तो मैं बगैर किसी देरी किए हुए जनवरी में मैं टाटा मेमोरियल हॉस्पिटल 11 जनवरी को मैं पहुंच गया था। 10 जनवरी को मैं पहुंच गया था और 11 जनवरी को टाटा मेमोरियल हॉस्पिटल में डॉक्टर से संपर्क कर लिया था। सबसे बड़ी समस्या ये थी मेरी, पहले जब डॉक्टर ने बताया कि आपको मुंबई जाना है, तो मेरे लिए सबसे समस्या तो ये थी कि मैं मुंबई आज तक कभी गया नहीं था। तो मेरे लिए एक नया जगह था, मैं वहाँ जाके किस तरह से क्या कर पाऊँ ये समझ में मुझे नहीं आ रहा था। तो अपने जो संपर्क के लोग थे, जो हमारे मित्र थे और जो भी संपर्क के सदस्य वहाँ पे थे, तो उनसे मैंने संपर्क किया और मुंबई में पहुँचा। और वहाँ जैसे तैसे रहने और खाने की समस्या जो थी वो हल हो गई। तो एक ठिकाना मिल गया कि यहाँ से रह के इलाज किया जा सकता है, पापा का करवाया जा सकता है। फिर मैं टाटा मेमोरियल हॉस्पिटल पहुंचा। फिर वहाँ उनका इलाज, डॉक्टर ने उनको देखा और टेस्ट वगैरह उनका कुछ करवाए, बायोप्सी करवाए। मैं आपको बता दूं मेरे पापा का 4 बार बायोप्सी हुआ। 4 टाइम बायोप्सी हुआ और फिर उसके साथ और बहुत सारे टेस्ट वगैरह हो रहे थे। 4 बार बायोप्सी के बाद उस सब में 3 महीने लग गए। तो मैं तो यहाँ से गया था ये सोच के बिहार से मुंबई की ज़्यादा से ज़्यादा 15 से 1 महीने में वहाँ सब कुछ ये हो जाएगा, उसी के हिसाब से मैं वहाँ से निकला था। क्योंकि पापा हमारे बिहार में एक ये है कि हेल्थ इंश्योरेंस पे पहले के लोग जो थे वो विश्वास नहीं करते थे, वो नहीं लेके रखते। तो एज यूजल मेरे पापा फादर ने भी हेल्थ इंश्योरेंस नहीं रखा हुआ था। और क्योंकि वो सरकारी मुलाजिम थे, एक सरकारी कर्मचारी थे, तो उनको गवर्नमेंट की तरफ से भी कोई सहयोग नहीं मिलने वाला था। ये तो पहले से ही मैं ये था मन में कि इतना तो मुझे लगा कि वहाँ जाने के बाद जो भी पैसे थे साथ में, और जो कुछ पापा उस टाइम में अपने बचा के रखे थे, तो वो लेके मैं पहुंचा था। लेकिन ये 3 महीने में ही वो पैसे खत्म हो गए। और फिर एक फाइनेंशियल संकट जो है वो उत्पन्न हो रहा था, और तब तक भी डायग्नोस नहीं हो पाया था पापा का कि एक्चुअल में क्या इलाज स्टार्ट किया जाए। फिर जब 3 महीने के बाद पापा का डायग्नोस फरवरी में जब हुआ, डॉक्टर ने किया, और जब उन्होंने इस पे खर्च के बारे में बताया, तो मेरे पूरे परिवार के पैर के नीचे से जमीन खिसक चुकी थी। क्योंकि उन्होंने इम्यूनो थेरेपी का सजेस्ट किया, और जो कि वो बहुत ही ज़्यादा कॉस्टली था। मतलब 21 दिन में 3,63,000 का वो दवाई आ रहा था, और 17 इंजेक्शन, मतलब वो उनको इम्यूनो देना था। तो ये सुन के ही कुछ देर के लिए हम लोग तो शॉक रह गए कि अब क्या होगा। तो फिर हम लोग वहाँ से निकले, डॉक्टर से कुछ 1-2 दिन का समय मांगा, और वहाँ से फिर निकले, जहाँ पे रुके हुए थे वहाँ पहुँचे। तब तक मानसिक रूप से और ज़्यादा परेशान हो चुके थे। एक तो पहले ही परेशानी थी कि जो भी यहाँ से बचा के, मतलब यहाँ से जो ले गया था वो 3 महीने में वो खत्म हो चुका था। एक तो परेशानी ये थी कि अब आगे का इलाज कैसे होगा। दूसरी बात कि जब वो इलाज के बारे में बताए कि इतना खर्च है, तो और मानसिक रूप से कुछ समझ में नहीं आ रहा था कि अब क्या करें। फादर थे, इलाज करवाना था किसी भी हद पे जाके। तुरंत में जमीन भी बिकने वाली नहीं थी कि गांव पे जाके जमीन बेच के आऊं तब फिर इलाज करवाऊं, उसमें 6 महीने, साल भर, 6 महीने कम से कम लगते। तो फिर अपने पारिवारिक सदस्य जो हैं और जो रिलेटिव्स हैं, उन लोगों से कर्ज लेना स्टार्ट किया। और उनसे कर्ज लेने के बाद इलाज जो है वो प्रारंभ करवाया। बाकी भी धीरे धीरे मम्मी के पास जो भी गहने वहने थे वो सब सोल्ड आउट हुए। अ, मानसिक परेशानी एक अलग थी। वहां पे रह के मतलब 7 महीना मुझे मुंबई में रहना पड़ा था। और रह के वहां पे एक नया जगह पे नए लोगों के बीच, और एक मानसिक तनाव एक अलग था, वो फाइनेंशियल तनाव जो था वो अलग एक ये आ रहा था। और हर एक 21 दिन पे वो 3,63,000 रुपया इंतजाम करना, मतलब एक इंजेक्शन लगने के बाद फिर उस दूसरे इंजेक्शन मतलब दूसरे इम्यूनो के लिए जद्दोजहद वाली स्थिति थी। कहीं से कोई होप नहीं आ रहा था, कुछ समझ में नहीं आ रहा था। एक सोशल वर्कर के नाते बहुत सारे पेशेंट को मैंने भी देखा था अपने क्षेत्र से ही कि बीच में इलाज बंद कर देते थे। वो तो बड़ा ये भी लगता था कि बीच में इलाज क्यों बंद कर रहे हैं, कुछ तो कर ले। लेकिन जब ये खुद से इस चीज में मैं गया, जब खुद पे ये चीज आया तब समझ में आया कि लोग क्यों और कैसे बीच रास्ते में इलाज बंद कर। एक समय तो ऐसा आया था कि मुझे भी लग रहा था कि मैं अब आगे नहीं इलाज करवा पाऊंगा और मैं उसे बंद करना ही पड़ेगा इलाज का। लेकिन किसी तरह फिर होते रहा, चलते रहा। और अभी 9 सर्किल का इम्यूनो उनका चला था, 17 चलने का 1 साल, और फिर डॉक्टर बोले थे हो सकता है कि आगे भी और बढ़ेगा। तो 9 हो चुका था और सडनली वो लास्ट मंथ 11 को वो पास आउट हो गए। लेकिन अभी वो तो चले गए हैं, लेकिन उनके जाने के बाद उनके इलाज में जो खर्च हुआ है, वो जो कर्ज मैंने अभी तक जो ले रखा है, वो मुझे लगता है कि 5 साल पाई कर पाऊँ पाऊँ। अ, उसके बाद ऑर्नामेंट्स वगैरह जो गया वो तो अब कभी वापस नहीं आ पाएगा। ये एक लोअर मिडिल क्लास भारी है। तो जो मतलब सच में जो इलाज नहीं करवा पाते हैं बहुत सारे लोगों को ये बहुत ऐसे हमसे ज्यादा मेरे तो कुछ पारिवारिक सदस्य जो है वो मदद किए, कर्ज के रूप में ही मदद किए, तो उस टाइम में हो गया। बहुत सारे लोग ऐसे भी हैं जिनको मदद करने वाला भी कोई नहीं है, जिनको देखने वाला कोई नहीं है। वो लोग हूँ या पापा चले जाने के बाद भी अभी भी मतलब मैं हॉस्पिटल से नहीं पा रहा हूँ। हाँ, से देखने के बाद लोगों अपने इतने ही से छोटे से कहानी से अपनी बात को समाप्त करता हूँ। है तो बहुत सारा कहने की चीज़ें, बहुत सारे कह सकता हूँ, लेकिन समय भी उतना जितना ब्रीफ मैं कर सकता था मैं बताने की कोशिश किया। मुझे आशा है कि आप लोगों तक मेरी ये पीड़ा जरूर पहुंची होगी। जी धन्यवाद।
थैंक यू प्रभात जी, अपनी कहानी शेयर करने के लिए। शारमीन ने शुरुआत में बोला था आपके लिए कि बहुत हिम्मत चाहिए इस सब से बीतने के बाद एकदम आके उस बारे में बताने के लिए, तो उसके लिए बहुत बहुत धन्यवाद। मैं जो लोग पीपल हु कांट अंडरस्टैंड हिंदी, आई विल जस्ट ट्रांसलेट इट फॉर देम व्हाट एवर ही सेड। भूमिका हैज बीन helping us in the chat, but I will summarize briefly of what Prabhaji shared with us. He started by saying that his father initially had cough and was there were some tests which were done, and then he was asked to go to Mumbai for further evaluation. In Mumbai, he was biopsied 4 times, and the diagnosis took almost 3 months. To reach a diagnosis, it took them 3 months, and during that time, he had his all his savings had run dry. So whatever money they had taken from home, and those who know, Bihar is in north part of the country. Mumbai is almost 2,000 kilometers away from Bihar. So traveling that far to reach a place, and then in within 3 months they ran out of all the money, and this is when they had not even reached the proper diagnosis. And because in Bihar, people did not believe so much in the concept of health insurance, they did not have a health insurance also, and there was no support also from the government. And finally, after they reached the diagnosis, they were told that he will require 17 cycles of immunotherapy, and the cost of each cycle was close to a lakh, 1 lakh rupees. And that led to a lot of psychological stress as well, just besides the financial stress. And he said that to raise that kind of money, it was not even possible to sell their house, because selling the house would also take 6 months. It won't just happen immediately. So they had to start borrowing money from the people they knew, and they had also had to sell all the assets they had, the jewelry and everything that they had to sell it. And they had to stay in Mumbai for 7 months, during which there was a lot of psychological stress, because after each cycle of chemotherapy, they had to figure out how to raise money for the next one. And during this time, they had also lost hope, and they felt quite hopeless in how they would keep raising that money for these chemotherapy cycles. Um, and as a social worker, he had previously noticed people go through this, and he had wondered why people would stop their treatment. But now, finally, when he was going through it, he realized what the main issue was. And after completing 9 cycles, last month his father passed away because of the disease. And he says that all the financial debt that he has incurred during this time, even though his father is no more, it will take him at least 5 years to regain that financial stability. And yeah, and that's only the loan that he has taken. All the assets which he has sold, he'll never get them back. So the 5 years will only take for the loans to get settled. And he's saying there, at least he's still being positive, and he's saying that there is, at least he had people to help him out. But there are a lot of people who don't even have supportive family members or other people in the community, and those who cannot afford any treatment at all. He is also speaking for those people who are even less fortunate than him. थैंक यू प्रभात for आपने अपना पूरा ये कहानी बताया, इसके लिए बहुत बहुत धन्यवाद. Vandana has joined us. Vandana, my next question is for you. In your experience, I mean, you have with a lot of people with malignancy and who have required counseling. I think somebody's. A second, okay. So, how often do people reaching out to you struggle because of financial burden of cancer, and how does it impact them? Be it physically, be it mentally, be it socially. Could you share some of your experience in that?
Thank you, Parth, and my apologies for joining in late. प्रभात जी, आपने अपना एक्सपीरियंस शेयर किया, और प्रभात जी के साथ हमने बहुत क्लोजली काम किया है. So let me just start with a story. I have, in my last 10 years, I've interacted with a lot of patients and families. So there's this young boy from West Bengal. He's a barber by profession. His father's diagnosed with an advanced stage disease. He comes to a hospital, and he's told that his father has a mutation positive cancer, and the treatment for it is a targeted therapy drug, which is costing 83,000 rupees. 83,000 rupees per month. Okay. He's a small time barber in West Bengal. So he calls me and says, I don't even have assets worth that much that I can sell. Right. Through the help of a couple of NGOs, we do manage to get him the help. He reaches out to the CM. Our social workers instruct him to reach out to the CM funding, the PM funding. So he's exhausted everything in the last year and a half. Father is doing very well. He's doing very, very well, right? So now we tell him that, hey, let's call him Mr. R. Hey, Mr. R, your father's doing very well. The same treatment has to continue. But unfortunately, you've run out of all sources of funding. Please manage the money on your own. So he calls me again and he says, this is a curse for me. By saving my father, you've put me under more stress. Tell me what to do. Go back to the doctor. Please speak to my treating doctor and tell him I can't do it. Reduce the dose of the drug. So imagine this is what financial toxicity looks like. So there's a son. We give him hope by providing funds. And then we tell him, look, we can't do it anymore. His father's doing well. So now without money, he cannot survive. As we all know, a stage 4 disease without medicine means death in a couple of months. So he keeps calling me and says, I don't have. So why are you even giving me false hopes? I can't take care of my father. It is better he dies. I have one small shop. If I sell that shop, I'll get close to about 60,000-80,000 rupees. So this is the reality, harsh reality of cancer care in India. So Parth asked me, what does the psychological distress look like? The first question when anybody experiences a cancer diagnosis is not whether I'm going to live or not. It is where will I get the money from? That's the first question that they ask, because the treatment, even if it's covered in Ayushman Bharat Yojana for the underprivileged or the people who fit into that criteria, 5 lakhs is nothing. It's absolutely nothing. And with the advancement in cancer treatment now, with the TKIs, the immunotherapy coming in, we give them a choice of choosing these drugs. We show them the carrot and tell them the carrot is inaccessible because you don't have the money. So what does it do? It not only adds, first of all, it adds to their guilt because they're not rich, they can't afford it. Then there is worry and fear. Worry and fear because not only a patient, the stress on the caregiver is also immense. We come from a society where we are very close-knit families. And the caregiver is compelled to take care of the family members. So what does it do? Huge psychological distress is huge. So it starts with worry and fear on how they're going to manage the money. The worry and fear over a period of time becomes anxiety and depression. There is, for the patient, imagine what the patient goes through. The guilt the patient goes through is unimaginable. They see their caregivers struggle. They see, they don't talk about it, but every day they see their caregivers struggling to make ends meet. While, through NGOs, we may also be able to provide medicine, but the catastrophic expenses, who caters for that? Now, these people living in West Bengal or maybe Bihar, travel to a place like Mumbai. In Mumbai, we provide them with funding for the treatment. I've seen people not being able to afford a 50 rupee lodging. I've seen people fall at our feet crying that we are getting medication, but we don't have 10 rupees to eat. What are we doing? Where is this leading us? So, in all the advancement cancer care has made, I'm really happy that we have made so much advancement in cancer care. But are we really taking care of our people? Are we really taking care of the people is the question that I ask everyone and of the government of India also. The financial toxicity breaks the back of people. And it affects the family dynamics also. The relationships are strained. There are times when I spoke of the guilt of somebody who's been diagnosed. There are times where the caregiver feels the loved one has been diagnosed is a burden on them. And there are times when they say, I wish he were dead or she were dead, because I can no longer take care of them. I can no longer provide for them. So Parth, I would say, overall, when we think of it, the impact is huge and we don't talk about it.
Thanks, Vandana. You have touched a lot of issues with our cancer financing. I think some people mentioned Ayushman Bharat, but when we look at Ayushman Bharat, which is for Shamin, which is our India's public health insurance scheme, Ayushman Bharat covers only inpatient care. And for example, like Prabhat ji mentioned, most of the cost goes initially in the diagnostic part of the journey, when you have to undergo all the tests, you have to move to another city to get that treatment or even the diagnosis. And Prabhat ji mentioned he finished all his finances within that period itself. And that period is not even eligible for Ayushman Bharat, because Ayushman Bharat, the insurance comes into the picture only once you're admitted and you start treatment. And in our country, a majority of the people finish their finances even before they start treatment. And and most of the time, our health system only looks at the cost of drug and the cost of the chemotherapy and the cost of the test in very rare instances, but they miss out on that cost of accommodation, like you mentioned, the cost of food, which are called the direct non-medical expenditure. So when people travel to another city, they have to spend now on lodging, they have to spend on food, they're missing out there on their daily income. So a lot of these things are still not being considered, which brings me to Dr. Ravi. Uh, Dr. Ravi, you have in your vast experience, could you share how this financial toxicity has impacted the diagnosis and treatment journeys of people in your region, and how what is the impact on patient outcome when we talk about it? Over to you, sir.
Thanks, Pa. Um, there are two things that I want to, or actually three things that I want to highlight. One is, see, we have been fortunate in that we have support from organizations like the Indian Cancer Society that offers, and then the Mahesh Memorial Trust, and some several organizations that offers support for patients that we see for initial diagnosis and the early treatment. And so over the last, in the beginning, it used to be a problem. The greatest, when a poor patient comes to the hospital and the initial diagnosis costs 10, 12, 15,000 rupees. And if we are not able to handhold them through that process, if they lose trust, they will simply disappear. They will not come back. And then, organizations started coming forward to bridge this gap. And so patients that we see in the hospital are helped. But for that support, they would drop out of treatment. It used to be a regular feature in the early days. The second thing is, see, Ayushman Bharat, I understand, is far from perfect. But somewhere we have to start. And over time, I think the whole system will improve. Ayushman Bharat has definitely helped more patients complete treatment. There are, as you say, there is no support for travel, there is no support for boarding, there is no support for lodging. So all that is there. And I think if we strengthen our public health system, if we strengthen the government medical colleges and district hospitals, along with the Ayushman Bharat, I think that would be, I think that will happen in due course of time. It's inevitable. The more we focus on private healthcare, the more the problems will be, because private healthcare has a different objective. Apart from taking care of sick people, they're also beholden to their shareholders, and so that is not going to happen. But Ayushman Bharat, focusing on public health infrastructure and probably not for profits may be the direction that we will eventually have to take. The third thing, this something I want to highlight as part of this discussion, is we've spoken about people who need targeted therapy and immunotherapy and things like that, which is expensive and which actually benefits, except for Herceptin, trastuzumab, and maybe rituximab. Most of the targeted therapy actually helps a very small proportion of patients. If you look at lung cancer, it is not that all lung cancer, the scenario has changed. A small number that have these um, molecular changes, the mutations, are benefited. That is one part. Definitely, that is important. But an even bigger problem is people who we treat with regular low-cost drugs, cisplatin and 5-FU. So we treat them for 6 months with chemotherapy, radiation, surgery. If you look at how many of them, in our area, head and neck cancer is a very big population. And if you treat them with curative intent, initially they lose wages. They're not able to go to work when they're on treatment. But if you look at people who have completed treatment and see how many actually go back, we did a quick survey a few months ago, and nearly 80% of our patients have not gone back to productive life. In other words, we have given them low cost or no cost treatment. CMJY has supported them. Indian Cancer Society has supported them. The hospital has supported them. They have not spent money on boarding, lodging, treatment. But the family has lost daily incomes. And then when the man or woman goes back, he or she is no longer, engaged in productive work. And so we have cured somebody. Good, they are happy, but we have given them an additional burden. There's one more mouth that is non-productive that has to be fed. And so that is also, we cannot speak of healthcare in isolation. Healthcare, livelihoods or loss of livelihoods, and education, they're all very, very closely linked, and we cannot in isolation look at healthcare, forgetting their, the social aspects of livelihood and education of their kids. And so that is something also that we need to talk, which is probably a bigger elephant than just some expensive drugs which have to be continued indefinitely.
Thank you, sir. That's a very important point of, is life, prolonging life enough without dignity and productivity after that. Shamin, I'll come to you now. How are things in South Africa? You've heard a lot about the scenario in India. Are things the same in South Africa, or are you facing some different issues?
Thanks, Parth. Yeah, I think we can learn from each other actually, rather than you just learn from us. So things are a bit different in South Africa. First of all, we're a smaller country with a vastly smaller population. And that's important because in South Africa, we have two health systems, a private health system, which serves about 15% of our population, and then our public health system, which serves about 85% of the population. So obviously the very wealthy who can afford health insurance or medical aid access the private health system, and those who cannot access the public health system. We've also got a 30% unemployment rate, so a lot of our people are not employed. Where it's different in South Africa is there is a tiered system for payments for treatment. And if patients pay their initial amount, it's based on their income. Basically, all the treatment they get is virtually free of charge. So they pay their outpatient visit, which is maybe 200 Rand, which is about $10 US dollars. And all the investigations that are done at that visit are free of charge. It costs them 200 Rand. And if they're admitted to the hospital, they only pay a certain amount. And then anything that is done during that stay is free of charge. When they go for chemotherapy, they only pay for the visit. So the treatment they get, they don't pay additional amounts. So I think it's very different in that while we have a public health system that doesn't really work that well and is really broken, oncology patients really get value in coming to our hospitals. But that being said, exactly as you're experiencing there, we can treat the cancer, but we cannot provide the accommodation, the support, the transport that the patients need. And so for us, the financial toxicity is often related to the psychosocial side of getting treatment. So a lot of them travel far distances. It's a 3-day trip from their rural village to their local hospital, spend the night there, get the transport the next morning to the tertiary center, get their treatment, and then the reverse. So it's 3 days off work, it's 3 days of traveling, providing food. And for those that are in the cities, it's very expensive for them, the transport. So that's the major issue in South Africa, and there's no support for that. Again, like you have, some of our NGOs do help with transport costs. There's also an NGO here that will provide a home for people to live in close to the tertiary center where they are getting their cancer treatment. So they pay a very small fee, and then they spend their however many weeks there accessing treatment and going home. And then some of our hospitals will have a ward that's almost a boarding facility. So your patients coming for their radiation treatment will be admitted there, not as sick people, but just a boarding facility so the patient can get their treatment without incurring the costs of travel. And obviously it's a minimal fee for that. So I think our systems are different. I think one of the challenges we have, or one of the good things and a challenge, is we have quite a strong social support system in grants that people can apply for. So, we do have what's called a disability grant. And once somebody has been diagnosed with cancer and is going to go through their primary treatment, they access this grant, which is about 2,000 Rand a month. So what's that? About $100 US dollars a month. But that grant is only active for the period of primary treatment. So once they've completed surgery, chemo, radiation, and like in the case of breast cancer or prostate cancer, they now go on maintenance treatment, that grant falls away. So that patient still has to travel to and from the hospital, but they're no longer getting financial support. And then there is another small grant, which is called a grant in aid. So it's only about 500 Rand, which is minimal. That's for the person taking care, so the family caregiver. But again, it's not enough to support that person. It's almost a token, and that falls away as well once the patient is in remission. So while we do have some processes in place to support our patients, and I think we are not grappling as much with financial toxicity with relation to the treatments, there are other sources of financial toxicity. Just briefly, in the private sector, what often happens is, obviously, because of medical aids and access to medications, patients will be treated until their funds run out. So there's always a cap to how much can be spent. And once they reach that cap, then they are just literally cut loose and sorry, we can't do any more for you. And then they move over to the public health system, which obviously will not be giving them the treatments they got in private. So sometimes you'll see there, patients feel the pressure, or the families feel the pressure to continue paying for those very high costs for treatment, selling their houses, their cars, as is happening in India. And in that private space, there is no support or no grants or anything to support those people. So while they're earning well and they're getting access to treatments, they do sometimes fall off in terms of costs and what it costs to the families.
Yeah, thanks. I mean, sounds like the private sector is doing the same job in India and in South Africa of destroying families. But it's good that public health system is stronger in South Africa from catering to 85. In India, the private health sector caters to around 60% of our population. So it's really the other way around here. And it's good to know that there are these grants which specifically help people, and India also has some of these grants for patients. But again, because of our large numbers, the accessibility becomes poor. प्रभात जी, मैं दोबारा आपके पास अब आना चाहूँगा. पहले राउंड में हमने we have looked at all the challenges in our first round of discussion. Now I think it's time to move to solutions. तो आपने जो कठिनाइयाँ झेली उस समय पे, आपके उस टाइम पे दिमाग में क्या क्या आया कि क्या हो सकता है कि ये ना हो पाता मेरे से अगर कुछ सुविधा होती. ऐसे कुछ सुविधाओं के बारे में आपने सोचा उस समय, कुछ दिमाग में आया आपके?
मैंने एक तो सरकार की तरफ से कोई मतलब सरकारी सहायता मिलने की तो कोई उम्मीद थी नहीं, क्योंकि पापा गवर्नमेंट सेक्टर में थे, जॉब कर रहे थे, तो उस हिसाब से उनको नहीं मिलना था. लेकिन एक गवर्नमेंट को ये सोचना होगा कि एक लोअर मिडिल क्लास के जो फैमिली हैं उसके लिए भी आप हेल्थ इंश्योरेंस की सरकार की तरफ से, केंद्र सरकार की तरफ से जो है वो मतलब लोअर इनकम में जो है उसके लिए है. लेकिन एक जो 40,000 45,000 50,000 रुपया जो कमाता है, तो वो उसमें नहीं आता है. तो और जो कैंसर का इलाज का आपका कॉस्ट है वो नहीं झेल पाएगा. वो महीना का वो 40,000 45,000 50,000 रुपया लेके आता है, और महीना में उसका वो खत्म हो जाता है. वो सब लगा हुआ महीना का 1 तारीख को उठता है और 5 तारीख को वो सब बढ़ जाता है. तो गवर्नमेंट को इस चीज पे सोचना होगा, उनके लिए भी सोचना होगा, क्योंकि जीने का अधिकार उनको भी है. और मेरे ख्याल से सबसे ज़्यादा अगर कैंसर के इलाज के बीच से कोई छोड़ने वाला कोई ग्रुप है तो वो लोअर इनकम ग्रुप वाले जो हैं, जो लोअर मिडिल क्लास के जो लोग हैं वो ज़्यादा छोड़ते हैं बीच में। जो मैं भी एक सोशल वर्कर के रूप में काम किया हूँ, और मुझे भी ये देखने को मिला। अब तो मैं अनुभव कर रहा हूँ, मैं ये चीज को तो अनुभव किया हूँ कि एक सडन एक टाइम ऐसा लगा कि मैं भी नहीं कर पाऊंगा। और शायद पता नहीं, अभी तो 9 ही हुआ था, 17 तक आते आते क्या होता ये मैं नहीं कह सकता हूँ। लेकिन ये गवर्नमेंट को ये सोचना होगा, उनके लिए भी सोचना होगा। और सही में डॉक्टर रवि ने कहा 5 लाख में नहीं होने वाला है। एक मतलब सिर्फ ठीक है, आप खर्च मत दो, आने जाने का खर्च मत दो, रहने का खाने का खर्च मत दो, लेकिन इलाज का पूरा प्रॉपर वो भी नहीं हो पाएगा। एटलीस्ट 10 लाख से तो कम में होगा नहीं। वंदना मैम भी इस चीज को कोट की है, तो मैं भी ये अनुभव किया हूँ कि अगर उसके लिए भी, अगर जो जिनके लिए है गवर्नमेंट अभी तक की हुई है, तो उनके लिए भी 5 लाख में नहीं होने वाला है, उनके लिए भी 10 लाख करना ही होगा गवर्नमेंट को। और एक अच्छा, बहुत ही अच्छा, मतलब केंद्र सरकार का तो इस बार बजट में मैंने देख रहा था कि देश के हर एक डिस्ट्रिक्ट में डे केयर, कैंसर डे केयर खोलने का उनका ये प्लान है। अगर ये हो जाए तो बहुत सारा सहूलियत होगा। ये जो दूसरे दूसरे, जैसे कि मैं बिहार से ही यहाँ आया, मैं पटना में हूँ, और टाटा मेमोरियल का एक मुजफ्फरपुर में यहाँ पे है, तो मैं वहाँ फॉलो अप ले रहा था। मतलब इम्यूनो उनका जो दवाई था वहाँ पे चल रहा था। वो मैं बॉम्बे 3 महीना पे या 2 ढाई महीने पे वहाँ, इसके बाद जाना स्टार्ट किया था। 2 बार मैं गया था, तीसरा बार ये मैं गया था अभी लास्ट दिसंबर में, 30 दिसंबर को 2024 को। तो गवर्नमेंट को इस सेक्टर, इनके लिए भी वो सोचना होगा। एक तो कैसे, मतलब 5 लाख में नहीं होने वाला, अगर जिसके लिए भी आप कर रहे हैं, मतलब गरीब के लिए ही कर रहे हैं, लो इनकम वाले के लिए भी, तो उनके लिए 5 लाख में नहीं होगा, उनको भी 10 लाख करना होगा। और दूसरा कि लोअर मिडिल क्लास जो है, जो कि महीना का जो कमाते हैं, वो 5 तारीख को वो पूरे उधारी वाले को वो दे देते हैं। तो उनके लिए सोचना पड़ेगा, ज़्यादा जरूरी है उनके लिए सोचना। क्योंकि वो एक ऐसे स्थिति में होते हैं कि वो दूसरे से मांग भी नहीं सकते हैं, और उनको कोई हेल्प भी नहीं कर सकता है, किसी तरह का हेल्प भी नहीं आता है, और दूसरे से वो मांग भी नहीं पाते हैं। तो इस पे थोड़ा ये करना होगा। दूसरा, प्राइवेट सेक्टर को भी और थोड़ा सा ये बहुत सारे बहुत करते हैं प्राइवेट से, नो डाउट। मैंने तो टाटा में रह के देखा है, मुझे भी, मैं भी उस चीज़ का मुझे भी बेनिफिट्स मिले हैं। लेकिन फिर भी और चाहिए। जिस तरह से अभी गवर्नमेंट, मैं तो एक उदाहरण दे रहा हूँ कि जैसे गवर्नमेंट ने बच्चे के दिल में छेद होने का जो इलाज करवा रही है, उसमें जो वो खर्च दे रही है, वो देना होगा। और कुछ मेडिसिन में, जैसे कि आपको टारगेटेड मेडिसिन है, इम्यूनो है, बहुत ज़्यादा कॉस्टली है। उस पे गवर्नमेंट को सोचना होगा, या किस तरह से उसको कम किया जा सकता है, टैक्स माफ करके, टैक्स हटा के उस पे, या कैसे उस पे मदद किया जा सकता है। बहुत सारे टेस्ट पे आपको वो टेस्ट में वो कार्ड जो है, मतलब आरोग्य जो कार्ड है, वो काम नहीं आता है। वो आप जब आप ये क्या कर रहे हैं उसको, आप जब जाते हैं ये टेस्ट करवाने के लिए इसका पूरे बॉडी का, तो वो मिनिमम 12,000 रुपये का खर्च आता है, 13,000 का वो उसमें इंक्लूड नहीं है। गरीब आदमी 12,000 रुपये कहाँ से लाएगा, जिसके लिए वो आप कार्ड बनाए हैं, जिसको आप 5 लाख रुपया दे रहे हैं, वो टेस्ट कहाँ से करवाएगा, वो 12,000 कहाँ से लेके आएगा। इस पे गवर्नमेंट को सोचना होगा। बस
मैंने
बाकी आप लोग हमसे ज्यादा, ये तो अपने अनुभव में बताया कि मैं ये अनुभव कर पाया हूँ। बाकी आप लोग हमसे ज्यादा है, क्योंकि आप लोग के पास ज्यादा लोग आते हैं, ज्यादा आप लोग बहुत करीब से उनको आप लोग देखते हैं।
तो थैंक यू प्रभात जी, दोबारा अपना जो सुझाव है अपनी तरफ से बताने के लिए। Uh, I'll just translate it for others again. He mentioned that Ayushman Bharat is only for when we look at the eligibility criteria for the Ayushman Bharat, it looks at the lower 640% around of the socioeconomic caste census based on 2011. So it's the poorest to the poor that come under Ayushman Bharat, which completely misses out the middle class and the lower middle class. So this significant proportion of the population is not covered by any health insurance, and this is what Mr. Prabhat was mentioning, that people who are earning 35 to 40,000 rupees per month still cannot afford cancer treatment, but they are not covered by any government scheme. So there has to be some provision for this population, which is not very poor, which is earning enough to sustain, but a cancer diagnosis can destroy that family. He also mentioned that 5 lakh rupees of insurance is not enough specifically for cancer treatment because the treatment is so expensive. The money gets over quite quickly. The private sector needs to pitch in more and support people with cancer more. And the government has to look at reducing cost of drugs, either by addressing the tax issues, or the other thing which can be done is, because the generic drugs are found in India, so by promoting more generic drugs. And the lastly, he said the cost of tests, which either should be covered by the insurance, or in some way should the cost of tests should be reduced. So these are the solutions which Mr. Prabhat suggested. Vandana, I'll come with the same question to you. Based on your experience of talking to so many people over the years, what gaps do you think exist and how can they be filled?
Thanks, Parth. Prabhat Ranjan ji, thank you for raising that point. And before I answer your question, Parth, I want to again, give a real life example of how people, middle income people, like Prabhat ji said, lower middle income. So I was interacting with a family where the gentleman was earning about 45,000 rupees per month, and as per what they told me, they were doing very well. They had a house, and they had one daughter, and they were doing very, very well. And then he got diagnosed with soft tissue sarcoma on the face. He went to a very big private hospital, and he told me by the time he had the surgery and the treatment, he'd lost everything. So he comes out, he moves down to a rung lower, another private setup, where I meet him. I speak to his wife, who's crying. The reason is their daughter, who's 6 years old, they don't have the money for her schooling. So the money that they have and the savings that they have are all being directed towards the treatment of the gentleman. The daughter does not have any money to go to school. She does not have money to buy books. She does not have money to buy uniform, which further adds on to their total pain. Where can they go? They can go nowhere, because this is, again, they are in a private setup. So private setup does not provide any kind of NGO support or government schemes. And for that matter, a lot of private setups do not even have Ayushman Bharat. This is something that I want to highlight. Not all private setups are offering Ayushman Bharat. So what happens? It is a couple of us, a few people who get together and arrange for money for the daughter's education books. But there is no fixed organization or an NGO support that can help her out. So when his disease progresses, he's dying, he wants to go back to his home in Jharkhand. He gives a call and says, I want to get an ambulance to go right away. They have no money for the ambulance. They have no money left for the ambulance. So, we make a couple of calls, reach out to people, arrange for money, and get him there, and he dies in his hometown. But this is what financial toxicity looks like. So again, coming back to what Prabhatji said, the lower middle income really suffer a lot because they have no schemes for them, and the government definitely needs to do something about it. How can we provide, help, or how can this change? While I have said a lot of things, the lot of unmet needs that I've spoken about, I would also like to highlight the government. There are lots of schemes that are available, which a lot of people do not know about. So therefore, we need to strengthen our patient navigation systems. train our social workers who can talk about different schemes that are available. There are schemes like the CM Fund, the PM Fund. There are schemes like, uh, a girl child scheme is available. Different states have their own support financial schemes. So when somebody steps into the hospital, they've got to be made aware of these schemes. So if we have patient navigation systems or social workers who are trained to do this, a lot of initial distress can be resolved. We also need to encourage open communication between the healthcare professionals and the family dealing with the cancer diagnosis. What happens is this does not happen. I mean, this does not take place. So it's very important right at the time of diagnosis. It doesn't matter which setup they walk into, private, public, uh, tertiary, anywhere that they go. So an open communication happens, which tells them about the entire cost that they have to incur when the treatment begins. A lot of times this does not happen. So this is something that should be brought into it should be done at the time of the diagnosis. I would also say part that it's very important to have mental health services. We don't have mental health services. So it is, generally taken for granted, or maybe just presumed that a person or a family undergoing so much will be able to deal with it. So we need to we need to include trained professionals who can provide the right psychosocial support at the time of diagnosis. So that's what I have to say about it.
Thanks, Vandana. Again, two very important points of patient navigation. Even I have noticed in the government hospital here, when you inform patients about the scheme, most of them don't even know these schemes exist. So just telling them about it is helping them have that to suffer lesser from that financial burden. And also, like you mentioned, mental health services. Second highest suicide reason for India. The second most common reason for suicide in India is illness. And a lot of people suffer not just financial but also psychological burden of diseases. So like you said, mental health services is a growing need in the country. Dr. Ravi, I'll come back to you. Cachar has created a lot of these interventions to address financial toxicity. Could you tell us a bit about the work that you are doing in Assam?
So, see, all our strategies have been organic. We have not looked at databases and tried to address. We just found a problem, addressed it, and moved on. And so because they lose wages, we started off by giving ad hoc employment on campus. We actually borrowed this idea from the MNREGA, where they give ad hoc employment for 30 days, So we just borrowed that idea. And then, uh, the in Assam, we have boat clinics along the Brahmaputra. And so they go from island to island providing healthcare. So we borrowed that idea and started making home visits. We looked at the fact that every time we had a consultation process valid for a month. So every month, if they have to pay consultation, so we quickly removed that, and we removed all these repeat charges for endoscopies, for biopsies, for consultations, for physiotherapy. So it improves compliance. The whole attitude of the staff, to reflect a pro-poor philosophy, the way we talk, the way we present the hospital, the value, the architecture, all of it, So on one hand, we went about reducing cost. On the other hand, we went about fast forwarding. So for poor people, if say you come back tomorrow for a biopsy, come back 3 days later for a pathology report, come back again for an immunohistochemistry, they will just slip through the cracks. So we fast forward diagonal by variety of means. We use frozen sections, we several things, and then we use technology wisely. like throat infection, for example, teleconsultation, for example. And then we always use only generics. So we don't buy any of the originator molecules. And so like that there are, over the years we put in, but what we realized is, each of one measure alone has not made a difference. We actually audited the impact of ad hoc employment. And we realize that when we do all of these things, it instills confidence in poor people. That what we realize is patients are afraid to go to hospitals because they think that when they go there, they will be out of pocket. And each of these measures to improve patient compliance is actually a confidence building measure. And all of it together reassures the patient that if they come to the hospital, they will be taken care of. That is what I think.
Thank you, sir. So, like you highlighted, there's a need for a patient-centric approach where patient is the center of our planning rather than the disease or the diagnosis. Uh,
When we go into the community for awareness for early detection programs, in addition to the early detection program, we also tell them about the various options they have to support their diagnosis and treatment. Because many of them are not aware, as Vandana pointed out, they're not aware of what is available in the environment, in the system. And so to make them understand that they have healthcare is a right is a task in itself.
Thank you, sir, for sharing those interventions that you've been working on in Assam. Shamin, is there anything that India can learn from South Africa? Is there anything that we can possibly replicate here now that you've heard of a lot of our problems?
Yeah, I think we're not really doing this very well, other than what the government does do. I think there are two approaches. One is to always advocate for patients' rights, and that's kind of an area where we can't always make a big difference. But I agree with Vandana in that we can make a difference in our own sort of circle of influence. And I think when you have lack of support for patients for cancer care, I think the patient-centric approach is really important. Patient navigation is important, and this has been identified in South Africa, especially in the private care, because as you, Ravi, say, the patients don't always understand that there are supports available to them. They don't always understand the true cost of the care. In South Africa, there's often a co-payment if your medical aid doesn't cover the full cost, but no one explains that to them. So they are needing much more information in what is this actually going to cost and what's it going to cost me and what is the total cost of this treatment, rather than let's just look at what each treatment costs and we don't know how long it's going to be for. And I think conversations with patients is really important because I think patients need to understand, well, the physician needs to understand what is the financial situation of the patient. And there's the whole ethical issue of, do I offer a very expensive treatment that I think they're not going to be able to afford? I withhold that information and offer them something less, or do I give them the full range and they make the decision? Where your caregivers may feel obliged to go for the best treatment, even though it's going to break the family financially. So I think that's a constant ethical debate. And certainly having mental health palliative care support right from diagnosis to help patients navigate all of these really difficult decisions and to support the clinicians in having these conversations with the patients and their families. I think that's the way to go.
Thanks, Shamin. I think this discussion that's a very good point of ending the discussion of how knowledge, awareness, and communication is like a low-hanging fruit right now for all of us to improve patient care and reduce the financial toxicity. As a part of this forum discussion, we are also launching a short film on cancer, financial toxicity, and advocating for a change. I'll just tell a bit about the short film now and where this work has been done. So this short film has been produced by the Cancer Foundation. With has joined us from the Cancer Foundation. You can see him on the top left, and Vid is a molecular biologist by training. But he's left the corporate side, come to the non-profit side, where he has started an organization to address financial toxicity of cancer. And Vid is involved in a lot of research and evidence building of how we can reduce this financial toxicity. So along with Vid's foundation, the Cancer Foundation, and Believers Church and Medical College Hospital, which is in Kerala, this short film has been produced to increase the awareness of financial toxicity and start the discussion around it. The film has been directed by Ria, who is again joined us in the call here. Ria is a community medicine physician who has also done her master's in public health and a course in filmmaking, and now is moving more towards filmmaking in the country to again bring issues related to health in the limelight through short films. Believers Church Medical College Hospital is located in Padma in Kerala, which is a 750-bedded NABH accredited tertiary care hospital, which is offering affordable, high-quality holistic care to people in Kerala and beyond. And as a part of Believers Church, Ria and few others have collaborated to start a society called MedMac, which was founded in July 2024 at the Believers Hospital, along with Nivarana, Shri Rural Foundation, and the National School of Journalism. And at MedMac, it's a dynamic platform that merges media, medicine, and arts for health advocacy. And through evidence-based approaches, MedMac hopes to make health topics accessible, engaging, and impactful through visual storytelling and creative media. And this work today that we are going to share next, it's called the Hope Circle, which is the production of Cancer Foundation association with Believers Hospital. And this narrative brings together professionals both from the medical and media world to craft a story that resonates with heart and authenticity. I will share the link of this video in the chat box, because while sharing on Zoom, there are some lag that we have noticed. I'll also be playing it on the Zoom as well, but do share it with the people in your family and as in your social media accounts, so that we can bring more attention to this issue. But I will also just play the video right here. So that was our first, I would say, in a series of short films that we plan to make to improve our advocacy on financial toxicity and cancer care in India in general. I would like to open the discussion now for people in our audience. If there's anything that you want to comment on or ask our experts today, please feel free to unmute yourself, and then you can go ahead and ask your question.
Hi.
Yes,
Hi, I'm Shani. It's not a question. I just wanted to add to the point. Psychosocial support is lacking, and it's not just we're talking here about financial toxicity for people who even can afford insurance. Is there? They have financial. They're good. They're able to take care of their finances and support treatment. Even they go through a lot of trauma and not knowing where this is leading. Like even there are some places where I don't want to take the name of the hospital, but recently I had to intervene for a friend's sister, and the family, of course, had the son and daughter, the husband, all of them had exhausted all their money, their savings, everything, and they had not done prognostication. The patient really had the hope till the last. They were doing immunotherapy and all those things, And they had no idea. 1 year in hospital, the patient was there and the family was struggling. Children were making sacrifices, and not even a psycho-oncologist had visited this family. They had, the collision was happening. They had not broken the diagnosis to the patient. So she was thinking, this will get better. Finally, she started telling, no, I think something is really wrong with me. And I happened to visit, and then I requested the family, of course, with the help of my friend, agreeing to it. And we said a psycho-oncologist must be met, and the family should know that they have the right to make the decision how long to go on like this, because 1 week's one medication alone was costing, I forget the name of the tablet, 2.5 lakh. And Bangladesh, it was available for lesser, and the doctors wouldn't let the family take this medicine from Bangladesh, saying that we cannot guarantee the efficacy. And the family were like, I asked them, how long would you do this? They were saying, as long as we can afford to, because if this medicine is not given, she will die. Eventually, she came away from the hospital for 2 days at home, and then she developed bleeding, and she went back to the ICU. The family made the decision, DNR, do not resuscitate. Still, the hospital was insisting, DNR, we will do mechanical ventilation, put her on ventilator. So the family again asked them, how long are you going to keep her on this? We don't want to see her suffering. Then the doctors came and said, she's having paralysis on one side. They were expecting she would go into DIC, and one side paralysis. Shall we do a MRI? They were asking. After DNR is given, then they said, no, her intestine is obstructed. So we'll do a decompression. Again, the family asked, why do you want to do it? It's just the play on the guilt of the family. Do not give them support. And finally, they said, they shifted the patient from the ICU to the room so family can meet. And family said, just put her on oxygen and let this natural process take over. 1 year, and the family did not even have time to, the counselor, we requested a counselor from outside to come into the hospital and help the family. She asked one question, how are you coping? The family said, we have no idea. This 1 year has been like, and now through this whole year, we're going to support the family for bereavement support. And I'm saying, what are we doing, even for those who can afford? And this is like, for those who cannot afford, it is like another world altogether you're opening for us. And this is very compelling stories that are there. I'm saying we are supposed to be caring, and another side, we are sitting there and we are kind of playing on the guilt of the families, caregivers, and then traumatizing them even more. I do not know how we can help people for what we have been in the profession. It's really, sometimes I wonder when people say like, resign to their fate and say like, we'll not do anything. Yeah.
Thank you, Dr. Shani, for sharing that. And it's quite a sad story that a lot of the time the communication is lacking from our side, I would say, the doctor's side. We fail to communicate the severity of the disease and also the prognosis. And you also brought up something which we have discussed in Nivarana's previous forum, which is advanced care planning, which I feel is very important in the context of cancer, because it reaches a point when no medical intervention will be beneficial for the person, but if no medical intervention with a curative intent. So I've in the chat box, I've shared our forum discussion on advanced care planning. Please take out some time to watch that. It explains what an advanced care plan is, how you can make that document for yourself, and all the details are mentioned in it. If you have any doubt, the information where you can reach out and ask us doubts is also mentioned there. I'm also mentioning our email ID for the Advanced Care Plan Task Force. It's called Advanced Care Plan India at gmail.com. And yeah, so once you watch that video, if you have any doubts, please reach out to us and we can help you create an advanced care plan for yourself. We have 5 more minutes. We can take a couple more thoughts if anybody wants to share anything or ask anything. There's also a Google form in the chat box. We would really like help in evaluating the short film that we have made. So please fill that Google form and help us understand what better can we do when it comes to making short films, because it's a long-term project that we are planning of making more and more such short films. So do fill that Google form as well. And yeah, I think Vid wants to say something.
Yeah, I mean, the point that Vandana made about the cost. So I spoke with many oncologists, and I've been asking them one question, that if a patient is diagnosed, that today is the day that you are going to break the news that person has cancer, then if he or she asks, how much should I provision for the next whatever number of years? Can you give me a number? And I spoke with so many people, nobody was willing to give a reply. They were saying, well, it depends upon the city, it depends upon whether person has insurance or not. I said, all said and done, forget everything else, just for an optimal treatment, how much the cost is. Insurance, private, public, that is how it will be paid for, and whether or not it may or may not be sufficient. But just tell me how much I should plan. And nobody was willing to comment that this is the number that you should plan for, and that was really sad. And so that is one point I really wanted to resonate with what you said. And जो और एक बात जो प्रभात जी ने करी कि I'll speak both in English and Hindi, कि आयुष्मान भारत, हाँ, जो एकदम बीपीएल के लिए है, उनकी सुविधा हो चुकी है उसमें, लेकिन बाकी के जो लोग हैं जो लाइक लोअर मिडिल क्लास है, जो एग्जैक्टली बीपीएल नहीं है, या भी ऐसा भी हो सकता है कि नौकरी चली गई या काफी कुछ हुआ और उसी दौरान कैंसर हुआ, तो ऐसे लोग क्या करेंगे? तो ऐसे लोगों की सुविधा आयुष्मान भारत में नहीं होती, और अगर इंश्योरेंस नहीं है, अगर भक्कम इंश्योरेंस नहीं, तो उसमें भी उनकी सुविधा नहीं होती। तो ये भी मैंने काफी देखा है। तो आपकी जो बात मुझे काफी मतलब दिल को छू ली आपकी बात। So which I was saying was resonating what Prabhat said, that people in India who are not exactly below poverty line, because in India the below poverty line is determined by the color of what they call as the ration card. And if you do not have that color, and you could be like earning not exactly BPL, but you're like in a lower income category, but you're not qualifying for that, then you will not get a good this Ayushman Bharat coverage. And if you do not have a good health insurance, then you are not even covered in that. And apart from that, so many other costs like traveling and so many other costs are not covered. And I've seen also that people suffer a lot, and which was also sort of a motivation to start this foundation and leave my corporate job, because irony was that in my corporate job I was responsible for sales, and for me to meet the revenue was important. And the question was where my revenue is coming from. And on the other side were people like, what Prabhat said, that, they had to sell their assets to pay for the revenue that I would help the company achieve. And I said, there's a problem with this. So just a few thoughts.
Yeah, thanks, Vid, for joining our side, I would say, on the other side of the corporate greed. Yeah, Vandana, I think you want to comment.
Yeah. So I first want to commend you, Pat, for getting people like me on board. Because what Shani said, there is a need for psycho-oncologists, counselors to be a part of the treatment plan. So thank you for getting me here, getting my perspective. And also what Vid said, the first question anybody diagnosed with cancer is going to ask, can you give us a rough estimate about the cost? That is the first fear that they have. And that's rarely addressed. So, it's very important that we have the treating doctor be a part of this conversation. I can't say it, a social worker can't say it. It's only the treating doctor. And also it's important, I'm not pointing fingers or blaming anyone. It is important to list out all eventualities. I once had a family reach out to me, Pat. The lady had recurrent cervical cancer, and we know what recurrent cervical cancer means. She asked me, nobody gives me a clear answer. We've spent so much money. And I asked her husband, have you spoken to the treating doctor about the prognosis? Do you know your wife is dying? 3 days later, she died. So they've spent all the money they have, and still the wife dies. So this openness, these conversations are very, very important part, because that is the only way you can prepare a family and in some way reduce their distress. Not all of it, but communication, open channels can definitely reduce the emotional distress. Thank you.
Yeah, thanks for that, Vandana. Definitely, we have a long way to go, and I think this discussion today is only a starting point to all that we can do in the coming years when it comes to cancer care in India. It's 8:30. I won't take much longer. So thank you everybody for joining us today. A special thanks to our speakers, Prabhat ji, Charmaine, Dr. Ravi, and Vandana. Thank you so much for taking our time to be a part of this very important discussion. Please do check out our work on nivarana.org, Nivarana. I'll share the website link in the chat box. You can sign up for our newsletter. We have these discussions once every month on issues that nobody else wants to talk about. So to do join our discussions and be a part of the change that we are trying to bring in this country and in this community. Thank you once again and have a lovely night, and thank you so much for joining us today.